We've got a second session now, which is about moving care closer to home. And if there is a policy that has been described as a bold new vision many times, it's this one. It is not a new vision. It remains bold, and it remains deeply complex and problematic to implement it. It has been something people have played at for ages, yet the gravitational force of hospitals and the power of hospitals continue in England to pull things back. So we did some work, which Sarah Reid, I did nothing actually, I don't know why I said we. We're sort of like a royal we. Sarah Reid and colleagues did work to look at some international examples. Maybe there's a different lens that we can look at things through. I would like to be clear, this is not about Singapore. I have this thing about Singapore because we're never going to be Singapore, just like to say that. So we've got a great panel with us, and I'll introduce them after Sarah has spoken. But we're going to listen to Sarah for a bit and then have a, I hope, useful conversation about why on earth it doesn't ever happen and what we could do to make it happen this time. Sarah.
Great. Thanks, Thea. Yeah, so as Thea said, my job here really is to set the scene for this conversation, and I'm going to do that by talking through some research that we recently published, looking at how some other systems have gone about implementing similar reforms to move more care out of hospital and into the community, and kind of the questions that's raised for us about our own approach in our 10-year plan. So in this work, we focus specifically on Denmark and Ireland, and we chose these countries for very particular reasons. For one, they both have deliberate long-term policies in place like us to reduce their over-reliance on hospitals, so quite handy, gives us something tangible to analyze. But more than that, we thought that they offered really interesting and differing contexts and experiences from which to understand our own problems and contexts as well. So on one hand, we've got Denmark, who, like us, is just at the start of their reform journey. They are just getting off the ground their policy aptly named Health Closer to You, which is all about moving more care into the community. But perhaps unlike the NHS, I think they're going into that reform with perhaps more favorable conditions to enable this shift. So a few of those examples may be that, Denmark historically has much higher levels of healthcare spending than we do in the NHS. They spend roughly, on average, 20% more per person than we have historically on healthcare in the UK. That will translate into having likely more resources, capacity, to kind of have the headspace to be able to enable reform of this size and scale. Likewise, Denmark has one of the most generous social care offers in all of Europe in terms of what people are entitled to from the state, very different from our own contexts. But again, this will probably convert into having more support and services in the community to help people live independently at home, rely less on the hospital sector perhaps. And thirdly, Denmark has a far more localized health system than we have. There's a lot more local control over what community health and social care services look like. And while centralization can be a real asset, like we have in the NHS, when it comes to designing services in the community that are best targeted to different local needs, having that degree of local accountability and localism can be quite an asset. So we chose Denmark because we thought it would be so interesting to see how a country that has some of these more favorable conditions in place is going about their reform, and what questions that may raise for us about our own process, but also equally show how this is still quite difficult, even in a system that has fewer of these systemic constraints. And then on the other hand, we've got Ireland, which we chose, we thought was instructive for really different reasons. So Denmark's just getting started. Ireland's about a decade into their reform called Sláintecare, which is doing many things, but at its core is really trying to deliver more integrated services closer to people's home. But what's interesting to us is some of the parallels in terms of the pressures that they're facing while trying to deliver this reform at the same time. So there's some really fundamental differences between our system and Ireland's, namely the absence of universal coverage being a huge one, but quite striking that, like us, in the aftermath of the 2008 financial crisis, Ireland has gone through a period of austerity measures that left health services overstretched. They have really growing problems with long waits in care. Those have only become more entrenched and endemic throughout the pandemic. So it's really interesting to see how a country is choosing and looking at how to deliver this reform in the face of some of those deep-rooted system pressures that look similar to our own. So what can we learn from these systems about how they're going about implementation? And I'll just pull out a few lessons from our report. And the first one I want to start is this one on political consensus. And this might seem like a really obvious point, but I want to start with it because it's the thing that we heard probably most consistently and with the strongest conviction from everyone we spoke to in both countries. And that is just how important having this political collaboration has been to the reform process in both of these countries. So in both Denmark and Ireland, their reforms were established by independent committees or commissions that then all parties in government have endorsed and signed on to. And when we spoke to people, they said that has been essential for allowing government to kind of focus on things that will take a long time to deliver. This is not a quick fix in any health system. It unlocks an ability to focus on things that are going to take more than one electoral cycle to solve. And I think, saying this and looking at the British political climate, I think a lot of you might be wincing. I'm American, I get it. This can seem fantastical, but I want to stress it because I think there's a baked-in flaw in all our policies that without this collaboration, we continue to have the short-termist view with policies and strategies change to deliver these objectives will keep changing every time there's a change in ministerial direction, government, leadership. So I think it's worth emphasizing and saying. The next point I want to make here is about money. I also thought it was striking that neither Denmark and Ireland are trying to make this shift happen without some upfront investment in community services. And that is to make up for years of underspending in those services to be able to take on this additional capacity. I think this stands in sharp contrast to what we've just heard in the session below and some of the data that Sally showed. But yeah, we see in Ireland, over the course of Sláintecare, health spending went up about 8% a year. Not all of that was for the community, but within that, they had ring-fenced budgets specifically for the community to kind of build out and scale some of the models that we're trying to do here, build neighborhood hubs in every community that will take on more chronic disease management and support for things like frailty. Likewise, in Denmark, we've seen them give kind of a recurrent uplift for overall health spending to their regional budgets. And within that, kind of ring fencing again some of this community spend to make sure that the money goes there and stays there. And I think what's interesting about Denmark as well is they're trying to better redistribute that spend. They have the same problem we do, where health resources have been concentrated in the acute sector over time. But to get away from that, they're saying, look, we know hospitals still need money. We're going to raise their budgets, but only in line with inflation and other, capital investments we're going to be making to those services. But any new money coming into your services moving forward has to be spent in primary care in the community to try to level that playing field. And I think that, again, just feels a bit different than our own 10-year plan, where there's some more, assumptions about how we're going to achieve this through savings made from doing more in the community without doing that upfront investments first. And I think that's just a bit hard to square with what we see happening in some other countries. Related to this, I think it's also worth reflecting that these reforms haven't come out of nowhere in either Denmark or Ireland, and they come on the back of other efforts to really build up the capital infrastructure in both countries to lay a foundation for this shift that just doesn't exist in the same way in England. So in Ireland, for example, starting the early 2000s, the government actually went through a primary care reform where they put a lot of money into revitalizing the buildings and estates in general practice. Those buildings are now the homes hosting these hubs that I've just described. They haven't had to start there with this new reform. They already have that infrastructure in place. Likewise, in Denmark, this reform that's focused on building up community capacity comes on the back of 10 years of Denmark really putting a lot of money and investment into its acute sector to make sure that its hospitals are world-class, state-of-the-art facilities. That has made this current reform far less controversial for the acute sector because they've been getting a lot of policy focus over the past decade, a lot of money to really make sure that their services are thriving, that they're in a stable position. And again, I think that feels pretty different to the context we're currently in our system. I also want to emphasize, so it's not just about money, it's not just about buildings. Of course, the shift is also about people. And I think one thing that really struck us about reading these other countries' plans is they had a lot more deliberate policies and changes to incentives that were trying to change the system behavior so that community care could become the default option, the easy thing to do. So what some of that looked like, for example, was in Ireland, they've changed a lot of the contracts. They said, we have these community hubs now. We need to make sure we have staff working in them. They've implemented new things like 50-50 contracts where nurse practitioners or consultants who are providing some of that care in the hubs are splitting their time evenly between the acute sector and community, and that time is protected, so they're not always being pulled back into their hospital roles when pressures rise. They've also given more money to GPs in Ireland to kind of have the time and ability to take on more responsibility for chronic disease management. In Denmark, one of the biggest problems they're trying to solve is that they just don't have enough GPs and other community roles in the parts of the country that need them the most. This is a similar challenge that we have. Really hard to shift care into parts of the country where you don't actually have people to deliver that care. So what they're doing is, again, changing the incentives. They're saying if you are a GP who is going to work in one of the parts of the country where we need you the most, we're going to pay you more to do it. You'll get more money for seeing fewer patients to accommodate and reflect the higher complexity of your case mix. They're saying we're going to make it easier and more attractive to train in parts of the country where we need doctors, reflecting that with evidence that people tend to work closer to the areas where they trained. So it's a lot harder probably now to become a GP in Copenhagen than it might have been 5 years ago. They're limiting the number of practices that can be set up in parts of the country that don't need them. So again, they're kind of taking this head on, thinking what are the incentives that need to change, and doing something about that in the plan. And I know our workforce plan is to come, but I think there's a lot of questions still left unanswered about how are we going to recruit staff differently, how are we going to train them differently, how are we going to retain them differently so that community care can become the default option. And my last point is that I think one thing that really struck me when reading our 10-year plan was that it spoke about the shift to the community as one with unequivocal gain, that there's no downsides to doing it. And of course, with any reform, there are downsides, and those things need to be anticipated and managed because it's inevitable with any system change. All the things I just described about those changes to contracts in Ireland and Denmark, they have not been popular. They have, if the GPs in Denmark are not striking yet, it is very likely they're going to be striking before the end of the year. So I think it's anticipating that some of this stuff is going to cause friction. How are you going to address that and bring staff along with you? And some of the other things that we saw occur in other countries that are worth noting. In Ireland, one thing, and this I think is relevant to the conversation we just had about what role the NHS has, but I think one thing we heard from GPs working in Ireland is they're saying it's great that we have these hubs now, they're expanding access for lots of people, but I have a feeling that a lot of the people I'm seeing are the ones that are already relatively well managed in their chronic condition. It's those patients that are getting more tests and having more appointments. I'm quite concerned that it's the people who I know are struggling the most that are still getting the bare minimum. So more activity in the community is not the goal in of itself. It has to be, as the question we had earlier, it has to be high-value care. Is it the right activity for the right people? Another issue that came up in Denmark was that all these controls and incentives that are putting tightening of activity in hospitals has meant that GPs are seeing more of their referrals rejected, and that has not gone down well. GPs saying, you're putting more risk onto me when I'm not ready for it. I still don't have the resources and capacity to do more of this complex work. So I think anticipating that these things will happen, they're inevitable, it's how we anticipate them and correct for them. And just in conclusion, before we go to the panel, the one point, if you take anything from what I've said today, the point I want to leave you with is, you may have noticed none of my lessons were about the pathways, the new models of care that we should be doing, what those models of care look like in Ireland and Denmark that we can lift, steal, and borrow. And that's because a lot of those pathways and models look really similar to what we're doing and have been trying to do for decades. Instead, we focused on how do we change that system hardwiring? How are Ireland and Denmark trying to embed these changes in a different way? And for me, I think that's what was really missing from the long-term plan. What are the incentives? Where's the investment? What's the capital going to look like? And it's, for me, where our current approach still looks weakest in comparison. Great. I'm now going to join the panel. So over to you, Thea.
Thank you. Really interesting, and hopefully we'll have a really good debate. And I'm going to start by introducing my panel. I have Kevin Mckenna, who is the MP for Sittingbourne and Sheppey. I have Liam Loftus, who is the Associate Director for Policy and Practice Engagement at Health Equity Evidence Centre, and is also a GP, but not currently a practicing GP. But if anybody faints, he'll still be, actually he won't, he'll probably turn to my colleague, who is a nurse and is also the Chief Exec of the Queen's Institute for Community Nursing and is a district nurse by trade. But we have part of a multidisciplinary team on the platform. And in fact, you're a mental health nurse by background, aren't you?
ITU nurse.
Sorry?
Intensive care nurse.
Intensive care nurse.
Sojourn is the ITU nurse, is the mental health nurse.
Okay.
And yeah, Paulette was the general surgical nurse.
Okay.
So we've got three
And
nurses.
back in my past, I was a clinical psychologist, so we have you covered. we are fine. You should feel really safe, and there are other clinicians in the room as well, which is great. So, I want to start by asking everybody the same question, which is, let's park at the moment what Sarah said. I'm going to come back to some of those issues with each of you individually. But let's maybe go in the way that Sarah did. It's 5 years' time. What will you see that means that it's worked this time? It's amazing. We're in the multiverse, and actually it's worked. Steph?
Thank you, Thea, for
You're
that
welcome.
nice, easy question to start with. So for me, I want to see the right investment in the right places, because I think that's essential for anything to change. So for me, that means a shift of resource into the community to enable that shift in care to the community. I want to see truly person-centred care. So this is care that's wrapped around the person, and that we're not just working in our silos of statutory care, that we're truly embracing the other sectors that we've got in our communities, like the voluntary sector, like faith groups, and like other community groups that we've got out there that can do amazing work. I also want to see us empowering people to take responsibility for their own health and care in a different way. So I'll say this, and I'll hope that you'll agree with me, but as nurses, we are trained to do things to people or care for people, but actually there's loads of things that people can do for themselves, but we don't allow it in our systems. If we did more of that, and we did more of that in the community, and where that's happening, it is making a difference, I think we will see the difference, because that will release people to be able to deliver the care that only a nurse can deliver, or only a doctor can deliver, or only a physiotherapist can deliver. So I guess what I'm saying in a nutshell is that truly multidisciplinary way of working, not forgetting the social care sector as well, because that is critical. I do think there needs to be investment, but there also needs to be work to make sure we're all doing the right things at the right time for the people that need it.
Okay, can I just ask you a little bit of a follow-up? So I'm your patient, and you're going to help me do things for myself. I just want to pull out, I don't want to, thank you, I've paid my taxes. I'd like you to do it for me, please, nurse.
Yeah, so we'd need an honest conversation, wouldn't we, about why would you want me to do something for you that you're capable of doing yourself? And is that about your fear of maybe doing that? Or is it something that you feel that you can't do? Or something that you feel you shouldn't do because of the reason that you've just said? But I think there's an honest conversation there about it's a finite resource, and I understand.
It may take you longer to have that conversation than mightn't it,
absolutely.
with you. You may need to sit with me for quite some time before I actually tell you that actually I like you coming because I'm lonely.
Absolutely, which is why we need to look at using our voluntary and community sector more, because they are the brilliant people who do that sort of stuff really, really well, freeing up the nurses to do the nursing.
But some of this will take time.
It will take time, absolutely.
So, Liam, how will you know that it's a brave new world?
That's a good question. I'm actually quite excited about what things could look like in 5 years' time. I think that's in particular for improving clinical outcomes, and in particular for improving outcomes for the people who already have the poorest outcomes. So if we think about some of the big headline measures that the government want to achieve when it comes to clinical outcomes, whether that be cardiovascular disease or improved cancer outcomes, I think we need a real focus on the people who currently have the worst outcomes, and we focus in that area, we're much more likely to meet some of those ambitious targets. And I think neighbourhood health offers a real opportunity for us to do that practically and to do that well. So that might be through the lens of, say, community health workers, where we have workers going out proactively, delivering personalised, preventative care to the communities and the people who would most benefit from it. We're already seeing emerging evidence about how powerful that can be. And also, as Steph has said, it's a real opportunity to work more closely with the voluntary community and social enterprise sector, where there does exist a whole lot of good capacity, good skills, and good motivation to want to be involved in this space. I think there's a whole load that we could unlock there. And also when it comes to neighbourhood health centres themselves, if we do go ahead and build them in the communities where they're most needed, and we do put in not just physical health, but mental health, and think more broadly about legal support, about citizens' advice, about return to work support. We've done some work on this at the Health Equity Evidence Centre, and there is emerging evidence that suggests that co-locating such services can improve access and outcomes for the people who would benefit from it the most. I think those things are really exciting. How will we know if it's worked? Well, in 5 years' time, I would like to see clinical outcomes have improved for everybody, but most importantly, that floor, the people who are struggling the most, that floor to be lifted much more close in order to narrow the gap that exists currently.
Yeah, we probably all know on this panel that 5 years you probably won't see that floor, and you may see a bit, and I think I'm going to take us back at some point to this long-term commitment to this and keeping the faith, which often doesn't happen. But Kevin, how will you feel proud that this has actually happened this time?
Well, I'm just glad you picked 5 years, because actually what we signed up for with the country is a 10-year plan for renewal. So in reality, and I think there's probably some realism in this room as well, we'll be part way along the journey. We will not be at the destination. And it was really interesting looking at the examples from Denmark, that was 10 years ago, and they've still got a lot to crack. So it's not, pardon me, about reaching the final destination, but it's about showing the public that we've really made big strides. And I think for me, it's starting off with the patient's experience and therefore my experience actually, and my constituents' experience. At the moment, most of the aggravation is can't get a GP appointment. I'm on a waiting list. I'm getting poor care from the NHS, actually. I think we have to be very blunt with ourselves, those of us that are clinicians or were clinicians. A lot of the care is not meeting my constituent standards. I mean, in my constituency, the hospital that covers most of my constituency on the new league tables is 5 from the bottom. So actually, I get a lot in my inbox about the standard of care that they're getting from the acute sector. So there's a real potential win here locally for me and across the country, particularly in areas with high levels of deprivation, that patients will start to see a much better set of results in their eyes. So not necessarily we're not just talking about health outcomes from a health outcome point of view, which you're right, will take longer. To lift that floor will take a lot longer. But people need to feel that meaningful difference. So yes, they need to be able to get an appointment when they need it. We need to have started to shift people's expectations about their own care. Despite lots of attempts at change, we've still got, I think, a lot of people have got a patrician model of healthcare in their head still. And that's as much patients as it is staff. And of course, staff have moved a long way towards that. Some patient groups have moved a long way away from that. But across the board, a lot of people still think it's a done-to system, that everything is done to them. So I'd like to see that shift. So I think on all those fronts, it's those basic things. People need to be feeling that there is a real difference, that we're on a trajectory to change. And actually, we want to see some dent in the numbers, in some of the negative numbers, absolutely. But it's much more that it's that we're on that 10-year journey, and 10-year, 20-year, whatever. So there's a long transition going to be here.
Yeah. Well, I'm with you, because I'm going to move back along this. You'll remember Sarah's first point, which was that the evidence from the countries we've looked at around political consensus and political collaboration. And what we have at the moment is a Labour 10-year plan, and we actually have quite a fractured political environment. And I'd be interested in your reflections on our learning from those international examples and where we currently are with a 10-year plan that is owned by one political party, and how you feel about that and what you think.
I mean, it is a challenging and fractured political environment.
Yes.
In many ways, we're struggling a bit in this country because we're less used to it than some of our European peers. At the same time, most of those European countries are going through similar levels of political instability and lots of reforming of political alliances and political parties and stances. I mean, the left shift in various forms has been talked about for a very long time. And, I always take it back because did some study of this a few years ago when I was doing a Darcy Fellowship on the Cogwheel report in the 1960s. So if we're going to take it back that far, this has been a very long journey. And the key thing about that is it wasn't very long after the founding of the NHS that those fracture lines were identified. In the early NHS, a lot of effort in that really shiny imperial phase of 20th century science. We saw new hospitals being built and great new, and actually community health centres, but a lot of new hospitals, and a lot of the focus was right on that acute care side of things. And it was seen in the 60s that there was a problem. And the fact that we haven't now, that was before I was born. The fact that in, 60 odd years now, we haven't been able to shift that is really telling, particularly when in recent times there has been nominally a form of consensus across this, certainly from people on the policy end of healthcare, certainly from a lot of politicians. If we go through from the things that Lord Darcy was proposing in the noughties, through to things that the coalition and then but particularly actually the later Conservative administrations, there was lots of talk about the left.
There was, but
so
I
there
think
was
what we're seeing is we don't, and I agree with you, I agree with you sort of vehemently, but what we don't have is what I think we've seen in these other countries, which is the formation of a cross-party political consensus that says whatever party comes into power, there will be a continuity of a plan. And you can't personally on this platform say, but I think there's some real learning to be had around how you get continuity rather than rebadging, re-engineering the same idea, putting it out in a new way, which is what we have.
Well, and this plan is very different from the previous 10-year plan. It's really interesting how different they are as a document. I mean, some of that's come from political reasons, but some of that's come from learning from what worked and didn't work about the long-term plan. So this is a more open document in many ways. It's less specific. And that's really coming from the policy world. I think in the politicians' world, I think it was really informative for me how conservative thinking in particular shifted during the time that they were in government, from an early set of radicalisation that frankly atomised the health system, to an understanding that no, actually the NHS was the right way forward, and largely in the way it's configured, we just need to change how it operated. And a lot of conservatives in that period got, I think, a stronger commitment to the idea of the NHS. So that carries forwards. Where there's a fracture now, I mean, bluntly in political terms, is particularly between Reform and the other parties. So that's where there's a big instability. I think when you watch Reform as they come into local authorities, they're confronted with a degree of reality about actually how public finances work, where the challenges are, that they're on. I can see them in my own county in Kent being on a very, very fast and steep learning curve. So we'll see where we get to in a few years' time. I think beyond that, we've got the KC review into social care. That is an attempt at cross-party consensus. I think we'd all like to see how that goes next year.
Yeah, I'm not going to go into the case review, otherwise I'm going to take this panel to a completely different place.
But what I was going to say about that,
so
just on that, so I think there's a lot about, there is room for cross-party consensus, and I think actually we need to make the argument, and from the policy side, need to make the argument to politicians. The other thing is just the personality changes. So it's not just the party changes.
Yeah,
we've had so many changes of secretaries of state in the last 10 years, and every time that's led to a shift. So it's not just grabbing the parties, it's actually the personalities and where those personalities decide to make their priorities. So that's something we need to focus on as well.
Definitely. Moving on, Liam, again, listening to Sarah and many other pieces of work, talk about the centrality of the GP and talk about the centrality of that figure, indeed primary care staff, but particularly the GP, in making all of this happen. And we saw also in one of the quotes from Sarah the issue of, well, hospitals are now rejecting more and there's no money. Can you just reflect for me broadly on the role of the GP in all of this and where are we up to and what is, somebody else is reflecting on their phone. And, is it going to work? Oh, do we have that foundation right? Talk to me.
It's a good question. I think there's a bit of an opportunity here, particularly when it comes to capacity within general practice and GPs specifically. So things have moved really far, really fast when it comes to how many GPs we have available to us in this country. As little as 2 years ago, if a practice wanted to recruit a GP, it was really, really hard. There weren't many of them floating around at all. But thanks to things such as us being able to train a lot more, and now a lot more of those trainees now qualifying, we've created two groups of GPs that we've not really had before. One is a group of underemployed GPs who are doing a number of days per week but would like to be doing more. And another is a group of unemployed GPs who can't get a job because the jobs don't exist in general practice at the moment. And because they're often recently qualified, they're often in the generation that I'm in, and they're people who I speak to quite frequently. And they see the most common thing I hear about the sort of concept of neighbourhood health is something that's quite exciting to them. If you can say to them, alongside some of their core clinical work, they can actually step out into communities and deliver things in a bit of a different way. And if you say to them, well, actually, there's an opportunity to develop a specialist interest in, let's call it dermatology, and maybe work with secondary care to reduce some of the waiting list that exists in that area, that seems quite appealing to them. And
Is that possible, Liam, though? I mean, that's quite an expensive model you're describing there. These GPs are stepping out. They're supposed to be driving down, seeing appointments, being more efficient and productive. Is this possible?
It's a good question. I might maybe come back to what Ed touched upon earlier, that it's if we're talking about true left shift and if some of that funding that follows, I think it's probably fair to say you get a lot more bang for your buck in general practice from recruiting some of these early career GPs to do some of this work than it would be to put an equivalent hospital consultant session on in the hospital. So I actually think, I think this is possible if we can get the funding flows correct.
Yeah, and it goes back to maybe I said at the beginning, the sort of gravitational pull of the hospital. It's possible. We don't have the history of delivering that, do we?
No, and I think there's challenges within general practice itself. Some of the reasons why this maybe isn't happening. I think as part of this conversation, we do need to think quite seriously about how general practice in its entirety is funded. So if you think about our 6,000 or so practices across the country, the vast majority of them operate as independent businesses. So if you are to ask more of each general practice without funding that follows, that has a real impact on their bottom line. And equally, if you're saying to general practice, we're going to take services away from you and take the money away from you, that equally has an impact on the bottom line. And what we're talking about in reality here, the bottom line for general practice, is how much partners, the owners of the practices, take home at the end of the day. So we're talking about having to make decisions that affect a bottom line, that affect somebody's take-home pay at the end of the day. That can be really tricky conversations when we're talking about funding flows and where it needs to be.
Okay, really interesting. Steph, community nursing also seen as being at the heart of the new neighbourhood models, one of the core clinical groups. Talk to me about how that's going at the moment, where you see that developing.
So I spend quite a lot of time going out and speaking with community nursing groups, and was out yesterday in the Peterborough area. One of the things I hear all the time, and I would absolutely concur with, is let's not develop shiny new services. We have got amazing community nursing services in this country, probably better than most of the rest of the world when you look at the different specialities that we've got. And I'm not just talking district nursing, I am talking about mental health, I am talking about learning disability, primary care nursing, the whole field of that community nursing. But there's something about building on what we've got and not creating new things. Because every time we create something new, we take away from, say, the core district nursing service, which has fundamental impact then on patient care. So for me, it's about building on what we've got now, thinking about the whole spectrum of community nursing that we've got and what do we need for them to be able to deliver in the way that we need it delivering. I think there's something going back to what I said about working with others. So don't think nursing can do this on its own. There's something about working in that multidisciplinary team and making sure that we're using and working alongside our AHP colleagues, our medical colleagues, but making sure that we're wrapping the care truly around the patient and looking at what they need. I think there's something for me, I've heard mentioned on this panel a few times when we talk about hospital care, it being referred to as acute care. I want to be really clear that acute care happens in the community, perhaps a lot more than it ever did in the past. So we in the QICM, we don't talk about acute care, we talk about community and hospital care being the two differentials. So I think we've got to remember that we are moving more and more care, more complex care, more acute care into the community, and we need the skills and the practical numbers of nurses to be able to deliver that.
Yeah, I'm surprised you've not used the figure, Steph.
Use it now.
Go on, use the figure. Use the
So
figure. I know you want to.
43% reduction in district nursing numbers in this country since 2009, which is huge, and at the same time a rise in need for district nursing services. So we've got to look at what does that really mean? What does it mean that we need going forwards? And I'll add to that, the issue that I'm talking about at the moment all the time, whenever I get a chance, is about care not done. In my opinion, the equivalent of corridor care in a hospital. So up and down this country, I can tell you as an ex-chief nurse of a community trust that we had hundreds of patients sometimes not receiving care on a daily basis because there was not the capacity to do it. So we were having to juggle what we had and look at where the main priorities were. But that meant that we were not delivering care to people who really needed it today. And what we're seeing, and in the Nuffield report this came through as well, is increasing numbers of coroner's reports citing lack of district nursing as partly the reason for somebody dying. And that can be because somebody's developed sepsis, because their wound care hasn't been where it needed to be, or they haven't had as many visits as they needed to be, or they've got urosepsis because we haven't been able to get out and change the catheter in a timely way. All of that stuff then leads to additional pressure on our urgent and emergency care systems, because if I don't go today to change somebody's catheter, the potential is it will block tonight. And then they'll end up potentially in an ambulance on the way to ED or in an urgent care centre, or trying to get a GP out in the middle of the night or a community nurse out. So it all has a knock-on effect. So for me, it's about investing in those core community services, because I think that will make a fundamental difference to being able to keep more people at home.
Brilliant. Sarah, as you know, we were hoping to have an acute trust chief exec on this panel who was unable to come at the last moment. So I'm going to ask you to channel the spirit of being an acute trust chief exec.
My dream.
Your dream. Everybody's dream. Although Wes was asked recently if he'd like to be an acute trust chief exec, and he's learnt enough now to say, no, I would not. I would not. So to channel that, what did you learn through your research? How did hospitals and hospital leadership respond to this sort of shift towards neighbourhoods?
Sure. Thanks, Thea. I think I'll draw mostly on Ireland for that answer, because I think Denmark is a bit different. Like I said, their hospitals are not in the same position that ours are in. This is a fairly less controversial change to be making. Denmark doesn't really have wait list, can you imagine, in the same way that we do. But Ireland certainly does. And I think what was interesting for me when we spoke to different hospital managers and system leaders is, they were quite honest and said, you know what, our wait lists are still pretty bad. Our emergency admissions rates, not where we want them to be. Those things have been really, really slow to change. But yet no one was saying the shift is the wrong thing to do, that they regretted Sancha care. In fact, they said, I can see other benefits. I can see that, things like getting your initial diabetes appointment with the consultant. In some parts of Ireland, it was a standard wait, 2 years. That was normal for a patient to tolerate. That's now more closer to 2 weeks. So they do see other benefits. We spoke to some GPs that reflected how their patients say, my experience of care is a lot better now. My mom at the end of her life wasn't going to hospital. That meant a lot to me. So I think people see this as the right direction of travel, even though maybe some of those hard metrics on hospital performance are slow to change. But I think when you have so many years of deteriorating performance and rising pressure in hospitals, there's going to be more than one answer to the problem. And I really worry that sometimes, and I was really pleased to see how Kevin was talking about this in a much well-rounded view, but if we see the benefits of the shift as a way of taking pressure off hospitals as its main aim, I think we will be disappointed in a decade's time. I think we really need to think clearly about what is this shift for, why are we doing it, and accept that some of those, those deepest rooted challenges in hospital may be the slowest things to change, and that doesn't mean this is a bad thing to be doing.
You make a very articulate acute trust chief exec with very profound views, which are really important because, I've been on other platforms as well. I think everybody on this platform says, it may well be that the way we evaluate this and understand this will not show up in immediate change to those acute trust indicators. And it really links back to a lot of what Sally was saying and other people were saying on the first panel about what we're seeing about how money is spent, what we're seeing about how public use service, what we're seeing with new drugs. There's so many things, but that won't mean to say that this is necessarily wrong. I'm going to ask, because I have two numbers written down here, I'm not sure if I'm chairing this till 11 or 11:20. 11, that's excellent, because there were two numbers written down, so I got very confused. Okay. I'm going to go to the audience then, although I had several more questions I wanted to ask the panel, but I'll go to the audience. Right. Individual here.
Thank you. My name's Zoe Worko. I used to be a geriatrician, and I moved into housing about 5 years ago, so I really went from one side to the other, and I spent all of my clinical time trying to set this up. We've talked about bringing the politicians along. We've talked about the importance of people taking greater responsibility for themselves, that this is going to happen to you. The other really important group of people to bring along is the staff. So people, whether it's GPs, community, acute, getting them working in a completely different way, comfortable with a different level of risk. So we know where we want to be in 5 years, and when you can see it in 5 years, as you said, Kevin, it's going to be amazing. How do we bring enough people along so they can start to see and feel, so we don't get the resistance from the patients and we don't get the resistance from colleagues?
Yeah, bringing everybody along, but bringing staff along. Who wants to reflect on that? Liam, do you want to have a reflection on how you bring all the staff along on this journey?
Yeah, it's a really good question and a really important point. In the context of neighbourhood health, one experience in my background sticks out. So for half my working week, I work at a large food bank organisation, Cambridge City Food Bank, as a development director, thinking about how food banks can think differently to tackle health inequalities. And one really, it was a really successful initiative that we started, was working with the practices in our local area, the GP practices. So let's see what would happen if we took your social prescribers and instead of them sat in the practices, they sat in the food bank just for 1 day a month, and let's see what happens. The social prescribers themselves were really on board with this, really engaged, and were jumping at the opportunity to get out of the practice into the community. We ran this, and then the outcomes that we got lots of engagement, we got lots of signposting to different services, and lots of really positive feedback. The project came to an end because at the end of the day, the staff that were back in the general practices, the management, was saying, well, this all looks great, but how can we evidence that the people that you spoke to in the food bank were definitely registered at our practice and not at other practices? And also, is there any way that we can show how this has impacted local A&E waiting times? So so what I'm getting at here about bringing the staff with you, the management themselves, they were super on board with this. They really wanted to make it happen and go out of their way to do so. But because of incentives and expectations that were coming from elsewhere, they felt like they couldn't. If we can give a bit more of that local flexibility and local freedom to let staff get on and do the things that they think will be most impactful, I think there's potentially a bit of a win-win there.
Yeah, I mean, I'm not going to ask everybody to comment because we've got lots of questions, but it definitely links as well with, I think, the question that was asked for the first panel, which is what can finance directors do and what is within your scope to be able to do, and how can you free people up to feel safe to say, go forth and do good work and be supported. I think a lot of staff want to go on the journey, but often there's too many blocks. Let me take another question. Right at the back in the corner. Otherwise, I know my eye will be drawn to the front all the time. So.
Thank you. Riyad Karim, Assistant Director for Communities and Health Equity for NHS England London. Just wanted to say thanks. It's a really great discussion. And Liam, what you mentioned about focusing the resources on the areas of poorest outcomes has to be a really important way to go. And I think in order to do that, what Dan mentioned in the earlier panel was about listening to stories and listening to our patients, not necessarily always listening to the fiscal dynamics. No elderly frail patient wants to feel, particularly if he's a retired GP who's served the community for 30 years, that he's putting pressure on beds. And it's kind of like really tapping into that lived experience. And when we look at our communities and the diversity of our workforce in London, Birmingham, Manchester, Glasgow, we'll also get a double hit in terms of positive trust if we're able to understand that myself and many other colleagues like me from a racial equity, but also my friends that have been brought up in Mansfield from a class equity perspective, we are bridge builders and we need to knit and stitch that workforce and community dimension. So I just wanted to talk about co-production and how important co-production is. Far too often we are dealing with stuff downstream, and we need to find out, like Bishop Desmond Tutu said, why people are falling into the river in the first place. So I think it's that understanding. We're far too reactive. I'll just give you, I used to be a GP practice manager in Chatham, assistant director of primary care for Enfield. I've got into communities because I just felt we're not engaging communities enough.
Yeah.
So yeah, my main job is about vaccines, would you believe? Why am I framing it to do with health? Because health and well-being, holistic, community-centered, one size does not fit all, has to be the way. So you mentioned, Liam, about CHWs and community health workers. That has to be the way. We also have to have a national group looking at, white English working group, looking at that as a community, because we are overlooking Doncaster, Mansfield, Medway, Sheppey, and for far too long, this has been an inconvenient truth.
I'm going to stop you because I think you probably will be preaching to the choir in this room, which is I agree, co-production, the need to listen to communities, the need to take stories to the heart of all of this, and making sure that we take that to the heart of it. I mean, Kevin, I don't know if you want to just reflect for a moment before I just bring another question.
Oh, I appreciate any shout out for Sheppey, because Sheppey erasure is a real thing if you look at maps. But anyway, but also it's absolutely it's the heart of a lot of this. How we reach communities that don't just feel they have been left behind. Of course, they hate being said left behind, but overlooked, and overlooked is probably a stronger way of literally like too hard, putting the too hard to tackle.
In American politics, they're often referred to as flyover communities, which we obviously we don't. We have trains, we sort of go past on the train communities. But I think there's something, it's a bigger reflection, but actually doing co-production and working with communities, it's a lot of work and it takes time. And we're actually also, cutting staff, cutting the people who do this. That's quite a problem if this is the way you want to do work.
And I think it speaks to something that was said earlier about the metrics around acute trust, and you always fall back on A&E wait times and so on. Yeah. Even with the best will in the world, everyone, whether they are senior executives and politicians, has what's basically policy panic. You suddenly hit a wall and you go, oh my God, this is not bending anything. And suddenly you have a panic. This is longer stuff. I think all of this speaks to actually how we, it's not just, we can talk in soft and fluffy ways that are actually good, how we get people to advocate for themselves, lead their own care, clinicians to lead their own workload and so on.
Yeah.
But at root, I think we've really got to understand what is really going on in people's heads. So we can talk about staff motivation and where staff are at in this. There is going to be resistance to staff. There is going to be resistance in communities. My community want a new acute hospital built, sorry to use the phrase, but that's what they want. They want a DGH built on Sheppey.
Oh, I'm sure they do.
Sheppey has a population of about 40,000 people. It's not the right place to put an acute hospital. At the same time, it's an island off the mainland, and people struggle to get to the local
but it tells us so much about
so
where
we've got to work with
heads
people, understand really what they want, because no, it's not that actually that DGH being built there is the right solution. It's not, but that's what people reach to. It's not, frankly, that immigrants and asylum seekers are using up all our social resources. They're not the root causes, but they are what people are grabbing as the causes.
Totally.
And staff are actually different but similar. Actually, why is there resistance? Well, a lot of it's territoriality, frankly. Stuff that, I think probably lots of us have learned if you've done change processes within a clinical setting. And it can be territoriality, frankly, from one ward to another. It's quite micro sometimes. And a lot of it is also, what did I sign up to as a clinician? What was my idea of what being a nurse or a physio or a GP actually was? If we're asking people to change that, actually, oh, well, I didn't sign up for that. And
Yeah.
this is true across the board.
And these are all the reasons why these
Yeah.
things fail,
Yeah.
generally. I'm going to take one or two more questions. Yes, here and here. I'm going to take these two questions and not look at the people who want me to finish exactly on time.
Hi, Sharon Brennan. I'm the co-chair of the government's TIMS review, which is trying to co-produce disability benefits for disabled people. My question is, it kind of comes off the back of the co-production, but how can we make sure that the VCC sector and communities are actually involved in neighbourhood design from the start? We talk about it being like a hard thing to achieve, but if we start talking with them at the beginning, rather than trying to kind of pinch them in at the end, we would get better outcomes. So perhaps open to you, Sarah, maybe on what you've found in Denmark and Ireland or including those people.
Okay, I'm going to take the second question as well, and then I'll parcel them up, I think.
Thank you. James Peskett from The ID as well. Thea, you did a really good job at the beginning of the morning of trying to connect that idea from the film of the multiverse to the NHS. Well done. I take from that it's about the interconnectedness of services. And I think it was interesting in the first panel that we touched a little bit on the pressures that are driving many public services to become more siloed and to draw more sharp distinctions between what they will and they won't do. So my question is kind of how neighbourhood health and hubs can try and be a force against that risk. And so, Sarah, I'm interested in what from Denmark and Ireland is really important about the wider local services, local public services context that we should understand in transferring those lessons. And to the rest of the panel, I wonder how we connect the health policy at a national level around the 10-year health plan to the other national policies around devolution, around economic growth and industrial strategy and skills. Thank you.
Well, so some very small questions to finish with then, which is clearly only going to take a few minutes to cover. So the first question, which is around having the VCSEs at the heart of neighbourhoods and the work. Part of the question was what we've learnt, but I'm going to come to you last and ask others experience. Who'd like to pick that up? Because I can't. Go on, Steph, yeah.
So for me, we have to treat them as partners and as true partners, not as somebody who's an add-on or something that might be able to be provided or might not be able to be provided. So they have to be part of the conversations right from the very beginning and understand what's best delivered in which area. And when you do that, I've had examples of that throughout my career. Actually, it works, and you get what you need in terms of the right people coming into the right places to deliver the right things, and making sure that you use the people with the right skills at the right time. So I think they've got to be seen as true, respected partners right from the very beginning.
Absolutely. Sarah, do you have any learning from the work on that?
Yeah, sure.
Area?
I can try to reflect briefly on both questions. So I think, on the co-production point, I mean, one of my regrets for this work is we didn't look directly at that question, though it is essential to this. But what I will say was, I was quite interested in how, sláinte care is like a household name in Ireland. The public really understand this reform. It's everyone knows what it's doing and why. And I think part of that is because the government is so transparent about communicating what it is and how it's evolving. I mean, there's quarterly reports that are communicated. There's dedicated time in Parliament to discuss the progress on sláinte care. They're constantly feeding back what we're doing and why, and what effect it's having or not having, and why that might be. So it's just, there's a lot of transparency built into their reform plan to bring the public along with them, which I think could be a valuable lesson there. On your point about kind of how local structures look in other countries, I mean, that is hugely interesting and a very distinct contextual point that is worth keeping in mind, particularly in Denmark. So in Denmark, it's the same bodies, local authorities that are overseeing a lot of the planning of both social care, housing, reablement, and healthcare. There isn't this divide between what the NHS does and what local authorities do in the same way. You can imagine that can help a lot of that, that shared accountability and coordination. Quite interestingly, though, Denmark is changing some of that. I didn't get into that, but a piece of this reform is actually taking away some of those health responsibilities and moving them back upwards because of issues they've had with variation. So I think that's an interesting experiment to watch, because we often talk about how that is a huge source of dysfunction in our own system, that we have that baked in fragmentation, and here Denmark is kind of creating that fragmentation. So just to say, countries do it in different ways. I don't know the right answer to it, but it's something to watch and learn from.
Great. In terms of the final two questions, are there any final reflections you'd like to make, Kevin?
Just very briefly, actually, you talked about devolution. I think devolution is really important, but more important for a lot of England is the local government reorganisation. Something a lot of people have not had a close enough eye on, mostly because people are obsessed with maps and they've been getting crayon out and drawing all over maps what they'd like. And a lot of that's been, again, interpersonal relationships. Oh, I don't like that person in that council, so we don't want to go with them. That's what's happening around the country a lot. We've got to make sure that it wins not just for local government, but also for the health system. And there is such a massive opportunity to align footprints and geography together with, my constituency, it's actually split. The district council covers 2 health zones in Kent. There is a huge potential win if we can actually split that local authority and put together like with like, socioeconomically like with like, as well as the health system and where those health boundaries are. Because the health has often been a challenge because we've got these fixed capital assets and, how people get to hospitals, how people access care, actually is more restrictive than some of the other parts. So the health voice has to be there, but there's a balance to that as well. A lot of colleagues in local government get very, very frustrated with the NHS. And their frustration is that where's the accountability? Whereas we've got lots of very big brains in the NHS who can make very big and strong, powerful policy arguments and have a lot of resources, but where is the accountability to communities and to what people are seeing on the ground? And people do feel that lack. And if we go down that line and actually align the NHS, social care, local government, which I think we need to do, we're also going to have to go, right, that starts to mean that local political voices become important in the health system. That will be quite a culture shock to the NHS, full stop, right? Not relating to Whitehall and not relating to NHS England, but starting to relate in a very, very different way to local politicians who, after all, for good and ill, in different ways around the country, as elected officials, we do actually reflect local will, and we've also got skills that you don't always tap into from the NHS. Since I've become an MP, I have been on a massive learning curve. I know so much more about my community now, and so much more about what matters to people, actually more than I ever picked up in clinical practice or at NHS England. And I think we need to be tapped into as well, and local councils even more so.
Thank you. I'm going to give you
30 seconds on the
30
working more
seconds.
closely with the voluntary sector. So I completely agree. I personally stepped out of my job in the consulting room in order to work in the community because I think there's so much we can do for health in that space. And I think there is will on both sides, both the health service and the voluntary sector, to do more of this. One of the problems in practice, to make it happen in practice, you often have to go so far above and beyond and push against the incentives, push against the current ways of working in order to make anything happen. And that goodwill, time and energy is really short in the health service at the moment. I'd really like us to get to a position where, rather than having to go above and beyond, this becomes more normalised, more accepted, and the space is created for it to happen well.
Okay, I'm going to bring it to a close because otherwise we will be here till lunchtime. Can everybody please thank my great panel?